Receiving a medical diagnosis is inherently stressful, but polycystic ovary syndrome carries a specific, heavy weight. For the millions of women diagnosed every year, the news often brings more questions than clarity about their future. By the time a patient reaches a specialist, they've likely spent months fighting a frustrating set of symptoms: irregular or missing periods, unwanted facial or chest hair, and persistent painful acne. Yet the name given to these symptoms, polycystic ovary syndrome, is a medical misnomer that creates a confusing, inaccurate picture of what is actually happening. The condition involves no actual harmful cysts, and the ovaries themselves are not the primary source of the disease. They are secondary casualties of a much larger process. Viewing PCOS as a localized defect of the ovaries ignores the evidence. The symptoms are the outward signs of a systemic communication breakdown. To find the source of that breakdown, we have to look at how the system is designed to work. The brain acts as a remote control for the reproductive system, using a dedicated hormonal pathway to send commands to the ovaries. The brain transmits chemical messages, specifically follicle-stimulating hormone and luteinizing hormone. These signals arrive at the ovary, instructing a single egg to mature and eventually triggering its release during ovulation. The system glitches when the body produces high levels of androgens, or male hormones. These androgens act as chemical static, jamming the brain's signals before the ovaries can receive them clearly. Because the ovary receives a corrupted command, the maturation process halts. The egg fails to develop, ovulation is aborted, and that undeveloped egg remains trapped inside its tiny sac, or follicle. When these undeveloped follicles accumulate, they appear on an ultrasound as a cluster of small, dark circles. Historically, clinicians mislabeled these as cysts, a term that stuck despite being biologically incorrect. The ovaries merely react to a distorted signal. To find the source, we must trace that androgen static back to where it begins. The question is, why would the body start overproducing these disruptive androgens in the first place? For most patients, the driver is a condition hidden outside the reproductive system entirely: insulin resistance. Insulin normally allows cells to absorb energy from the blood. When cells stop responding to insulin, the pancreas assumes there isn't enough and pumps massive amounts of excess insulin into the bloodstream to force a response. These chronically high levels of insulin circulate through the body and begin overstimulating the tissues of the ovaries. Under this constant metabolic pressure, the ovaries are forced into the mass production of androgens. This creates a biological trap. The excess androgens block ovulation, which worsens the hormonal imbalance, locking the body in a self-perpetuating loop. PCOS is a metabolic feedback loop, where runaway insulin and disrupted hormones continually reinforce one another. This is a systemic metabolic syndrome. When the central metabolic gear falls out of sync, the entire machine shudders, leading to the symptoms we associate with the syndrome. If this loop remains unmanaged, the reproductive consequences are significant. The lack of regular ovulation can lead to long-term infertility. Beyond reproduction, the high insulin levels present a different danger. Unchecked insulin resistance is the primary metabolic pathway toward the development of type 2 diabetes. The biological reality follows a specific equation: hormonal imbalance plus insulin resistance plus ovulation dysfunction. Identifying insulin as the driver shifts the treatment strategy. Instead of focusing solely on the ovaries, clinicians can prioritize managing insulin levels to restore balance to the entire system. Stripping away the name polycystic ovaries removes the focus from the symptoms and places it on the cause. Patients can stop fighting a misnomer and begin addressing the metabolic loop to reclaim their health.